Talks. So I have been waiting for this show for a very, very long time. We're going to give y'all a couple minutes to jump on board. We have a very, very special guest with us this evening. We have Dr. Gregory Dumanian. Dr. Dumanian, welcome to the Cosi Talks hot seat. We've been prepping him. We've been prepping him, folks. So hopefully we won't scare him away this evening. No, I'm kidding. So folks, for those of you watching the replay, especially my international folks, please put replay into the comments section. I do like to go back after the show is over and see who's watching the replay and also catch up with any questions. There are some of my first viewers coming in. Hey, Harsh, we got Harsh from Richmond, Virginia coming into play. Thank you for coming, Harsh. Guys, if this is your first time on the show, I don't like shy people. Please let me know who you are, where you're from, and more importantly, what's in your coffee mug this evening. Dr. Dumanian, you had an interesting coffee mug that you were showing me earlier. Do you still have it? It's in there, yes. Hey there, Pam, Marianne.
It is a chai tea mug from India. I got from the India Hernia Society for a talk. So
very good. Well, you need to put some next time. You got to put something in it for the next talk. That's just kind of the rule. So there you go. All right, we got Brett Sykes in snowy Phillipsburg with his coffee. Tom, there we go. There's my Canadian there. How you doing? Let's see who else we got on board. We got a lot of people popping on board right now. All right, guys, I'm going to give you another moment. I would like to take the time to thank my sponsor for this evening, TMR Nerve. We're going to be talking a lot about TMR. And guys, this is one of those episodes that you're going to need to watch more than once because we have a lot of information we're going to be giving you this evening. So for those of you who haven't had a chance to visit my YouTube channel, please go do so because it's a lot easier to watch the replays on those. And you're going to want to watch this one again. We've got Rita on board. We've got Susan from Alabama. Let's see. We got John Hook. Hey, listening to from the YouTube channel. We got Stephen on board from Jacksonville. There's my fellow Floridian. Another fellow Floridian, Susan Walker there. All right, guys. We're going to get started. For those of you joining me for the first time, welcome. My name is Cosi. I'm a physical therapist amputee specialist here in Tampa, Florida. And with me this evening, I always point to the wrong side, is Dr. Gregory Dumanian from TMR Nerve. And I'm going to let Dr. Dumanian introduce himself.
Hi, everybody. I'm Greg Dumanian. I'm sitting in Chicago. It's dark outside. It's 6:30 and or 7:30. I don't even know what time it is. And I'm the chief of plastic surgery at Northwestern, Feinberg School of Medicine. Why would a plastic surgeon do any of this? Well, many nerve surgeons started as hand surgeons, and a third of plastic surgeons become hand surgeons. So, it's a natural part of our specialty. So that's why I'm a plastic surgeon.
And this is interesting. So many of you were here last year where I actually had Dr. Leonard Dedesi, an orthopedic surgeon, on board to talk about TMR. And for me, I always love to hear the different perspectives. There are so many different surgeons that can perform an amputation, right? We've got general surgery, trauma surgeons, plastic surgeons, orthopedic surgeons, vascular surgeons. So each one brings a different perspective to the game. And your perspective, obviously, as the pioneer of targeted muscle reinnervation is especially unique. But I don't want to give too much away. So guys, I do want to make a note. TMR Nerve is managed by Checkpoint Surgical. Checkpoint Surgical is a medical device company that specializes in intraoperative nerve stimulation procedures, okay? So basically, if any of you have had a TMR procedure surgery, some of the tools used within the OR came from this company. And the reason how I came into contact with this company is because so many of you reached out to me saying you needed resources. You needed to find credible surgeons who had training for TMR. And I don't even know how I came across the website, but I did. And the company responded and they provided me with this beautiful list of surgeons that were trained in TMR. We've got a lot of people popping in. We've got Jennifer and David and the Captain's here on, Captain, it's a party. He's in from Phoenix. We got Jim Simpson on board. We got Michael Madre. We got a couple of clinicians here. It's going to be a fun night this evening, guys. All right. So as Dr. Dumanian mentioned, he is a plastic surgeon and he pioneered this surgery. So the purpose of tonight's talk is to tell you not only about targeted muscle reinnervation, but kind of tell you a little bit of the backstory as to how it came about and how it actually was helping upper extremity amputees. This is not a subject I get to cover very often on the show, so I'm so happy to show them a little bit of love this evening. Okay. And guys, I was reading some of those research statistics and I came across that there's 2 million Americans living with limb loss in the United States alone. And about 25% of them are experiencing chronic to severe pain due to painful neuromas. That's 500,000 people in the United States. And we both know that that's probably an underreported number. There's probably more than that. Okay. So this is something that can apply to many of you. Let's do a quick Cosi poll. There's Andrea, my occupational therapist. Welcome aboard, Andrea. How many of you have residual limb pain or have been diagnosed with a neuroma? Go ahead and put it into the comments section right there. And then guys, we're going to go ahead and just get started with our first giveaway. We love to do giveaways on the show, Dr. Dumanian.
Coffee cup? Do I get a coffee cup?
Do you get a coffee cup? You will get a coffee cup because honestly, coming into the hot seat, you deserve to get a coffee cup after this is over. All right, guys. So I mentioned to you that I became connected with TMR Nerve when I was looking for surgeons and physicians who were specially trained in this procedure. Stacy says that she has residual limb pain. Vic Graham says 80%. Patricia has it. Susan has it. So this is very applicable to many of you right now. I just posted the link to the directory, okay? And they have it listed by state. Here's what you have to do for this giveaway. You have to go to your state and type in one of the doctors in your state that is trained in TMR. Go. And we have some quick draw McGraws here, so we're going to start to see some answers pretty soon. The winner of this giveaway is going to have a socket sock. So guys, if you haven't checked out Joan McDonald's Socket Sock website, she is a small business company within the limb loss community, and we love to show her support. So Jennifer says she had TMR at the James OSU Medical Center in 2018. Let's see. Dr. Dumanian, are you seeing the comments on the right side? Are they showing up all right? Okay.
Yeah, for sure.
All right. Jim said, had a great promo discussion with members of the Amputee Coalition peer visitors. Wonderful. All right, guys. So I listed a website there from TMR Nerve. Okay. And you need to, Harsh already put one answer in. You need to go to your state and list one of the doctors in your state that does TMR procedure. All right. So while we're waiting for some of these answers to come in, we will go ahead and get started on some of the history. Now, y'all know I love to learn and I love to explore the whys and the histories behind a lot of these topics related to amputation. Okay. So TMR was actually created for upper extremity amputees, right? And our upper extremity limb loss community uses three basic types of prosthetic devices. They use a cosmetic prosthesis, which is exactly that. It's just meant for the cosmesis, just to look the part of the arm. We have a body-powered prosthesis, and those are typically attached on, right, and they are powered by the muscle. The individual has to do some form of movement with the muscle or the remaining joints to get it to work. And then we have the myoelectric, right? And y'all who know me, you know I love sci-fi. So myoelectric for me is just like days of sci-fi when I was a kid. Some people call this the mind control prosthesis, okay? The way the myoelectric prosthesis works, it picks up the electromagnetic signals from your muscle, okay? And after specialized training, a person wearing the myoelectric prosthesis can basically just signal and set off the muscle to start opening and closing the hand device. We've got a lot of answers coming in. This is great. So Dr. Dumanian, when did you start working with upper extremity amputees and the use of the myoelectric prosthesis?
So back in 2002, Dr. Todd Kiken, who was a physiatrist, a physician, but also an engineer, came to me and said, hey, you know, the problem with myoelectric prosthetics is that it's the wrong muscle that's trying to activate the prosthetic limb. In other words, you know, Cosi, you showed your biceps, but the biceps is not meant to close or open and close a hand. A biceps is for elbow.
Mm-hmm.
You want the hand opening and closing signal, which we, you know, normally have in our forearm.
Mm-hmm.
So for a transradial, okay, which is the most common upper extremity amputation, you have the signal. So you put on a device. If it picks up the extensor muscles, it opens the prosthetic device. If you get the flexors, it closes. That's intuitive. But as soon as you get near the elbow, you lose the open and close signal.
Yep.
So Todd asked me, how are we going to regain the signals that are still in the nerves but are just amputated?
Mhm.
And he had done some experiments in rats. And I said, I can do that tomorrow in a human. And he said, you cannot. I was like, oh, no, that's just standard peripheral nerve surgery. And literally 3-4 weeks after our first conversation, Jesse Sullivan, the first TMR patient ever, came to Todd's office and we did our first surgery on him. Though I have to say, I bankrolled all of TMR because I bought the first cadaver with some research money, and I did sham surgery, on a cadaver to see if
Yep.
things would reach, to teach myself, where things were. And then we did it on Jesse. And the funny story. So all these people who are doing TMR and getting TMR, my resident, while I'm operating, said it was the stupidest thing that he had ever done in his residency. So we don't have that many pictures of it because I was fighting my resident the entire time. I could give you his name, but I don't want to be called for libel on,
He's got egg on his face right now watching this show.
Super.
Yeah.
So we're still friends. So there was a junior resident with me at the time. So I let the junior resident write up the paper, not the senior resident or the chief resident who was just torturing me the entire case. And Jesse did fantastic. He could now think, and he was a shoulder dysarticulation. I did his other one. So he could think, and his median nerve was now innervating a muscle on his chest. So when he thinks, close my hand, that muscle would quiver and it would cause the prosthetic hand to close. All intuitive. He could now move multiple joints of a prosthesis at the same time. Previously, you would, for a very proximal amputation, you'd have to move one joint and then lock it in position and then the next joint. That's too slow. It's too non-intuitive. And so no one was using their devices because of that.
Yep. No, and this is the part for me that when I first started learning how to read this, I'm like, this is science fiction coming to life. 30 years ago, we only saw this kind of technology in science fiction movies. So folks, how does the TMR in the upper extremity work? And this is Bob, Dr. Dumanian. I haven't introduced you. This is my somewhat reluctant model. He participates on the show and he's a little snarky. So we're going to make Bob a shoulder dysarticulation for this evening. Sorry. So that's usually my favorite example on how to demonstrate how the TMR works. So when you have the shoulder dysarticulation, right, folks, you lose the entire humerus. You lose everything below it. It's all gone. What's left is a bunch of nerves, which we call the brachial plexus, that were formerly located in the armpit. And then you still have this big, beautiful, juicy pectoralis major muscle, right? And the thing of it is, with nothing done, that pec muscle is just sitting there doing nothing, and it goes to waste. So what I used to say, what surgeons have done, and I'm like, what Dr. Dumanian has done is created the procedure whereby they take, usually it's the three, is a median, musculocutaneous, and radial.
And ulnar, if you have a fourth spot to put it to.
Okay. And because the pectoralis muscle is so nice and big, you can allocate it to different locations. And like Dr. Dumanian mentioned, you try to put the nerve where it will be intuitive to you. So I'm assuming the radial nerve for extension, right, is put more inferiorly?
It doesn't matter because
Okay.
Really, because the prosthetist can figure out, okay, close your hand, they're looking for the median nerve, and wherever that fires, they put the electrode there. And so then after the surgery, the prosthetist can figure out where's the best signal location. So it's really it's very practical surgery. What reaches what? Where do things go? There's some patterns, but it's really where do things go? Now, as good a question, why is it called targeted muscle reinnervation?
You're targeting a motor point, a specific motor point in the muscle?
Yeah, maybe. But Todd and I were talking on the phone, and I was driving by a particular store. I'm not giving any store recommendations, but I was driving by Target, and I'm like, well, let's just call it targeted innervation. And I swear that is a totally true story.
That's just a royalty there waiting to happen somehow or another. I don't know. But it's an elegant surgery. It's a surgery that's utilizing this muscle that is still viable, still functional. And
not being used.
And not being used.
For an amputee, you lose nothing because that muscle isn't controlling anything.
Nope.
So it's a freebie. It's a so it really it solves lots of problems. But here's the issue, though. The number of people that have upper extremity loss above the elbow are really, I mean, there are too many of them still, but they're not that many patients. And so I do 2 or 3 of these every year, not more than that. It wasn't catching around the community. And the surgeons really didn't like the ideas of how you would take this big amputated nerve and put it in this small motor nerve. And that just really freaked everybody out. And so for 10 years, I'm talking about this at meetings, and really, other than one guy in Vienna, Dr. Osman, who's pretty famous now, no one was doing this operation. Someone mentioned Sonia Agnew at Loyola. I saw that, and she was one of my trainees. So so some of my trainees were doing it, but it really hadn't hit the big time yet.
There we go. And Harsh, we're going to be answering that question a little bit later on, and as well as Sue and Pam. We're going to be answering those questions a little bit later on, folks. So we're going to get to all of these questions as well. I think one of the things that really just caught my attention, I was just like, that is just so cool, that if you plug a sensory nerve in there from the hand and the patient touches their chest, they can feel their phantom hand.
Totally.
It just makes it that much more useful when they're using the prosthesis. So you just see this technology that's gone. If you think about it, folks, 20 years is not a lot of time. And we've advanced quite a bit in this technology, right? So my kids would say I'm geeking out right now because this is really cool stuff. So let's talk about, so how does this relate, to lower extremity? And as I was prepping for this talk, guys, and TMR Nerve was just so wonderful about sending me all the studies and all the paperwork, I came across the one study, and I'm kind of calling it the aha study, the aha moment. And it was a study that was done in 2014. And it was on 26 patients. And y'all, I don't normally bust out research statistics with you all, but this was a really well done study, and I really loved reading it. The 26 patients actually underwent TMR to prepare for upper extremity prosthesis. So everything that we just discussed now. And then when they looked back on the results, they noticed that all of these patients were reporting that their pain from the neuromas was gone. So of the 26 patients, and I'm going to break it down because I know I've got some clinicians on board, so I got to watch my P's and Q's here. Of the 26 patients, 11 of them never had pain, and they didn't develop pain afterwards. Great. The other 15 that had painful neuromas, 14 of them, the pain was completely gone. And then I asked Dr. Dumanian, because I was being a smart aleck, well, what happened to that one? And then he answered, what was your answer to me?
Well, the pain that patient had was in a nerve we didn't treat. So he had a painful nerve. We were doing TMR on the inside of the arm. We never treated the outer nerve, and he still had the pain afterwards because we hadn't really understood the power of TMR for pain. And I'm going to give a pep talk for all the prosthetists. When Dr. Souza, who was my trainee, who's now at Ohio State and leading, the reconstructive efforts there, he's a fantastic plastic surgeon. When we were doing these cases, we weren't asking about pain because we were so sure that putting a big nerve into a small nerve or a small nerve into a big nerve was going to cause pain. We figured if we were documenting pain outcomes that were bad, people would stop wanting the surgery. So we never actually were documenting outcomes for pain, but the prosthetists were. So Dr. Souza went to the prosthetics records, both at Walter Reed and at Northwestern. And it was great because Jason became a military person, so he was stationed at Walter Reed. So he had a connection there. And the prosthetists' pain outcomes, we used that to understand what the patients were undergoing. So go therapists. If it wasn't for them and they're writing and they're talking to patients, we wouldn't have these studies.
There we go. There you hear it. So Pam asked a very good question. Can you do this for brachial plexus injuries?
Yeah, it's been tried. I've done it 2-3 times. The outcomes are not overly good. You need a normal nerve leaving the brain, leaving the spine, going to the limb.
Okay.
We would love for that to be, that's the next frontier.
Yep. Yep. And then Dina says, I'm scheduled for TMR next month. I'm a 26-year-old elbow disarticulation. Thomas is saying, oh, he's the TMR guy. I met him in Vegas. There you go. So you have some folks that have met you already. All right, guys. And again, folks, we're going to be answering questions all throughout the show. If I do happen to miss your questions, I go back after the show is over and I pick up all these questions. Not to mention that I'm really easy to find. Y'all can email me, Facebook message me, carrier pigeon, and send me your questions that way if we miss them this evening. So let's move on to how this relates now to leg amputees. So one of my favorites, so I'm in Florida. And actually, one of my favorite cities, I'm going there next week, is St. Augustine. St. Augustine was the first city settled in the United States. Spanish colony at first, changed hands with the French, and lots of fights and all that kind of good stuff. My favorite tour in St. Augustine is the Spanish Military Hospital. The Spaniards, I got to brag about my background. They were amazing when it came to medicine, even back in the 1600s. They didn't understand anything about bacteria, but they knew that if they kept everything pristinely clean, their patients wouldn't die as much of infection, right? So a lot of the structure of that hospital reflects this hygiene. And during the tour, which I highly encourage you all to take, they talk about amputations. Pretty much if you got bitten by a mosquito the wrong way, you were probably looking at the very least, a toe or a finger infection or a finger amputation. And then obviously the more larger limb amputations. And I'm sitting there and I'm kind of chuckling in the back, and I'm just thinking, surgical technique really hasn't changed a whole lot since then. Thankfully though, our anesthesia is much better. That's for sure. And our pain management is much better after surgery. But how we handle the nerve, that's what's really improved. Okay. So in the, traditional amputation, the surgeon will cut through the skin, the soft tissue, the muscle. And then when it comes to the nerve, the surgeon will carefully pull the nerve, transect it, and then it will basically go back into the soft tissue. And then they close up the flap after they've cleaned out all the necrotic and the dead tissue, and off you go. Okay. So what happens is this nerve, as what Dr. Dumanian mentioned, this nerve is still alive and it's still flip-flopping around. I say idle hands make devil's work. Dr. Dumanian, you have your own saying.
It'll be in the video though, so I can wait.
Okay, you're going to wait to tell. Okay. So idle hands make devil's work, right? So this nerve is still
a hot wire.
It's a hot wire. Okay, we're going to call it a hot wire.
Hot wire.
It's flip-flopping around in there, okay? And it's looking for trouble because it's not doing its normal job of innervating a muscle. At this point, I am going to show off this beautiful video that TMR Nerve made. See, Dr. Money's like, shh, no more. And I'm going to go ahead and share this video, guys. Bear with me. As you know, my computer loves to play tricks on me.
The nerves in your body are like power lines. When a power line breaks in a storm, the live wire sparks because the energy has no place to go. Those sparks are like the pain you may feel after an amputation when your body's power lines get broken. There may be pain because the energy in the nerve is looking for somewhere to go and something to do. When a nerve is broken during amputation, it keeps growing to try to make a connection. If it doesn't find a connection, it can grow into a painful jumble called a neuroma. Or it may think it's still connected and fool the brain with confused signals from the missing limb, causing phantom pain. If you think about the live wire from the power line, the only way to stop the sparking is to reconnect the wire. TMR, or targeted muscle reinnervation, is a surgical procedure that reconnects painful nerves that have been broken by an amputation. In TMR, a surgeon fixes the power line by reattaching the broken nerve to a nearby nerve and the muscle it activates. This gives the nerve a purpose, with somewhere to go and something to do. A purposeful nerve is a happy nerve and one less likely to cause pain. Happy nerves mean a happier you. Learn more about TMR and whether it may be an option for amputation nerve pain relief. Visit tmrnerve.com.
Did that go through? Brett says, I like it. I was an electrician. There we go. Kim says, I've had several neuromas in the past 3 years. David says, Pastor David says, great stuff to know. Thanks. And then excellent correlation for someone who belongs to the energy industry. So you've got a lot of fans with this video here. So guys, I thought that video just explains it beautifully. Okay. It's giving, with TMR, you're giving the nerve, let me make sure I say it right, somewhere to go and something to do.
Yes, in Dr. Souza's and my paper in 2014, that's the last sentence. And it really changes how we think about cutting the nerve. The way you described it, Cosi, is how I was taught. A traction neurectomy. You hold the nerve, you tug on it, you cut it, and let it retract into the tissues by its regular elastic fibers.
Yep.
Totally the wrong thing to do. You want to leave it long so that you can route it somewhere, finding a local target for it, and you steal that target's receptors and let the nerve innervate that muscle. So when you think, close your hand, it's the muscle quivers, but there's a secret, and we haven't really talked about the secret.
Before you talk about, I'm sorry to interrupt. We're going to announce our first winner. It was Stephen. I forgot to say, I know, I'm so sorry to interrupt you. Stephen O, you are the first winner for our giveaway. Stephen, I know that you know how to find me with the email, so make sure you email me and go pick out your socket sock from the website of your choice. Dr. Dumanian, what is the secret?
The secret of TMR, the secret that no one really talks about, is that, you have to cut a nerve to allow that major amputated nerve to grow into the muscle. Right. Motor nerves, you can cut them without causing pain. All the nerves that cause pain are sensory or mixed. It's the sensory component. So the motor nerve you cut is a freebie, and you steal the receptor bed, and then you plug the hot wire into it. So that's the secret of TMR.
Bingo. Jill, the success rate, we're going to throw out some numbers to you in just a little bit on the TMR surgery in just a few minutes. So, who is a candidate, Dr. Dumanian? Who would you say is your prime candidate for TMR?
Well, I want to go into that whole upper extremity, lower extremity thing, right? We did this initially for upper extremity motion and prosthetics. And then Kaiken and I figured out that Souza figured out that pain was getting better. And then we applied the same concepts to lower extremity amputees, where there's 9 lower extremities for every 1 upper extremity. Using the same concepts, and we got the same outcomes, that pain was getting better. So who's a candidate? Basically, any amputee that's not, the nerves are still connected to the brain, they can have it done. I've done it at the buttock level. I've done TMR. I've done it for any kind of amputation, and people are even doing it for mastectomies. Any tissue loss with cut nerve endings. It doesn't have to be a limb or an arm.
Wow.
And then, you can use the same concepts for any painful nerve. Though this is talking about amputees, but we use the same strategies for the occipital nerve, for non-amputees with limb pain and painful nerve endings. So it's a ubiquitous strategy. But in terms of lower extremity, if you have got a limb that has good blood flow and you've got a target to put it to, almost anybody is a candidate if they have intolerable nerve pain. If they have tolerable nerve pain, you live with it and you take your medicines and you live with it. But when your pain becomes intolerable, well, there is something that you can try.
And that brings us to the next question. And Susan, we're going to get to your question because that's a good one right there. When should it ideally be performed?
Oh, great question. And this is Ian Valerio, who's now at Mass General, plastic surgeon, was in the military, friend of mine, developed it at Ohio State. So the two of us were doing a co-project, and more of his patients than mine, but he was doing it at the time of the amputation. And TMR done at the time of the amputation, before the cycle of pain starts, is even more effective than doing TMR when you have established pain.
Yeah. And that's playing into neuroplasticity, which is its own show that we will do. later on. That's a whole nother can of worms on that one. Now, for the folks who had their initial amputation, they're experiencing that intolerable pain related to a neuroma. Is there hope for them?
Yes, because TMR for both upper and lower limbs. And so, what are the numbers? If you are on the 6 to 8 to 9 on the 10-point scale, typically you'll go down 3 to 5 points. Now, most people are not pain free. And if you smash your finger on and you're really palpating a nerve, of course there's going to be some pain. There is this one lady, she was a baloney amputee, diabetic, lost her leg because of diabetes. Another surgeon, she developed neuromas. Another surgeon cut her neuroma. Okay. She developed intolerable pain. I did TMR. I didn't see her for 5 years. She came back to my office and she said, my pain is back. And I said, what do you mean? She says, well, when I'm on my prosthesis, 10 hours a day, at the end of that 10th hour, it kind of starts hurting at the end of the limb. I'm like, my feet hurt at the end of 10 hours on my leg. So, the issue is, what are you comparing it to?
Sure.
Right?
Sure. And then here's another part I want to segue into here. And those of you who've watched my show, you should already know this talk already. Understanding the differences between the pain you're experiencing. Okay. And I have some videos on this on my YouTube channel as well. You have phantom limb pain, phantom limb sensation, and residual limb pain. Okay. Residual limb sensation is phantom limb sensation is exactly that. You are feeling the foot that is no longer there. And if I had a nickel for every time a new amputee would come to my clinic and they would just look around and go, I can still feel my foot, because they think they're going crazy. Okay. It's a sensation. They either feel a little pressure, they feel their toes wiggle, they might even feel like it has a little bit of a tickle to it, but there is no pain. That is phantom limb sensation. Phantom limb pain is exactly that. It is a pain in the place where your foot used to be. Okay. It can be described as crushing, burning, electrical, tearing, all sorts of adjectives that have been used to describe this pain.
Cold, small,
cold,
small,
incredibly uncomfortable. And we've done countless shows on this, on conservative management, medical management. The guy who invents the cure for phantom limb pain is going to have his own island someday, which it might be him. So with the phantom limb pain, though, it's pain outside, right? Residual limb pain, okay, is pain in the limb that is still there. So when my patients talk about having pain, I tell them take their pointer finger and point to the pain. If they're pointing to the limb that is still there, it's residual limb pain. If they're pointing somewhere in the air, then that's phantom limb pain. And the reason why I really harp on this is because this helps us as clinicians determine what is the source of this pain. If we know the source of the pain, then we can hopefully come up with a treatment. Okay. Why do I keep bringing this up? Because every once in a while, I'll get an email from someone who says, I had TMR and it didn't work. I still have my pain. And then I go digging through that person's medical history, and it turns out they had a bone spur in their residual limb. That's what was causing their pain. And targeted muscle reinnervation does not treat a bone spur. Okay. And again, this is where I beat the dead horse a little bit more and say, if you are having residual limb pain, you need to go see a physician or a surgeon that knows what a neuroma looks like. Okay. Not all physicians and surgeons are going to know how to diagnose one, and they might miss it. Okay. So that handy dandy little directory on the tmrnerve.com, I've already sent many of you to it. And many of you have already told me that you've gone to see physicians just to help you diagnose. It could be that it's not a neuroma, that it's something different. It could be scar tissue, right? And then if it is a neuroma, there is a way prior to surgery to see if it will work. Correct, Dr. Dumanian?
Well, I like to, if there's a question, to inject numbing medicine just as a local test to see, oh yeah, I injected that numbing medicine and they're better for 2 to 4 hours. Well, that tends to mean if you play with the end of the nerve, that's going to help their pain. There are a few people, 1 in 100, 2 out of 100, that have something called centralized pain. Somehow you play with the end of the nerve and they still have the exact same pain after cutting the nerve again. And that's because there have been changes in the brain. Mm-hmm. Okay. Mm-hmm. So, and that's unfortunate. I'm not sure what can be done for that, but it's only 1 or 2%. And because the risk of TMR is so low, it still makes sense to try it, right? I mean, this is not brain surgery. This is a limb surgery. One, maybe a day in the hospital, sometimes two. It's not life-threatening. So why not try something which, in the majority of people, seems to decrease their pain?
And this is something, folks, thankfully, we have a couple of docs here in Tampa that do it. But many of you are facing revisions. And whenever one of you comes to me and says, I need a revision and I need answers for this and this and this and this, in my email back to you, I'm also saying, have you talked to your surgeon about doing TMR? Because if they've already got you open for a revision, it's like Dr. Dumanian said, it just makes sense. It just makes sense for them to do this. And now we have so many surgeons throughout the United States, it's kind of worth the extra legwork to go and try to find one of these surgeons. Okay, let's see. Yeah, Susan says it's a day surgery here in Canada. Susan is waiting for her initial meeting with her plastic surgeon to wait for the call to go in. Bill's got the bone spur being removed. Yeah, that's a different one. That's a different ball of wax there. Sorry, trying to read through some of these comments, guys. What are the contraindications? That's a great question, Vikram. I'm gonna let Dr. Dumanian answer that one.
I'm not sure there's a great contraindication where you're going to hurt the patient if you do it. Of course, we don't want to do unnecessary surgery, but you shouldn't work on a mildly ischemic limb. So for a leg, if there's no hair close by, that means the leg could, for a diabetic or someone who was a smoker, you don't want to cause a wound where you're operating. So if you have poor wound healing from poor blood flow. Mm-hmm. For the upper extremity, the brachial plexus injuries. So those, we mentioned those already. The surgeon needs to, you have to have good soft tissue. So you have to be able to cut, get down to the nerve and get out. So if there's someone with tons of heterotopic ossification, like some of our Army soldiers, you have to have a plan for closing. And if you don't, you could get, again, wounds. And if there's inflammation in a wound, the nerve ending will get scarred, and that's not a good situation.
Yeah. So basically, the person needs to be evaluated to be a good surgical candidate. That's your basic indication, as for any surgery. Right. Let's see. Susan says, do you cut behind the knee for TMR?
Well, the most common level of amputation in the United States is a below-knee amputation. When you do TMR acutely at the time of the amputation, most people, including me, do it inside the wound. So their surgeon is doing the amputation, and you can do the TMR inside the wound itself. But for a chronic amputee, an established amputee, then we do it with the patient prone on the operating room table, and you can get all the nerves in one incision this long behind the knee.
There you go. And then an earlier question, which I was like, that's a really great question. What happens if the nerve is really short? Is there always a way to reroute it?
Well,
or do you affect it more proximally, or?
There are, if the nerve is that short, then the residual limb is really close to for below knee, really close to the knee, or AKA really close to the buttock. So there's always, you can go one joint above if you need.
Okay. And then, folks, that brings us to our second giveaway. With this second giveaway, the prize is being a part of the Cool Kids Club. You either have your choice of a Cosi Talks mug or a Cosi Talks, I guess we can call this a beer glass. I drink my iced coffee in it. So the prize is this. And then what you need to do, I just posted a link again to the tmrnerve.com website. And folks, after the show is over, save this on a separate tab. They have so much information on this website. I want you to go to this link, and I want you to give me either a question or information that you need to bring to your doctor about TMR. So just put something like that into the comments section. So you're going to go to this website, and you're going to tell me a question or information that you should be bringing to your doctor about TMR. And then I'm going to answer the question that Jill had a little bit earlier. What are some of the outcomes? So speaking of Dr. Valerio, you mentioned he was at Ohio State University.
Well, okay, he was, and now he's at Mass General.
Now he's at Mass General. Well, the study I have here was from 2020, the Ohio State University, and I need to go back and see if he's probably on that study as well.
Oh, he is.
And it was a study done on 25 traumatic amputations. And guys, 25 people may not sound like a lot, but in the world of amputees, a study with 25 is actually a pretty decent number. Okay. So what they did is they did the TMR on these traumatic injuries and they checked them 14 months afterwards. So a year and change afterwards. And here are some of the statistics, which I thought were very impressive. 92% of these patients reported feeling no pain or just very brief little intermittent pain. Okay. But what really caught my attention is that prior to the TMR, 16% of these people were taking opioids. They were opioid dependent because of the level of pain. 50% of them discontinued the use of opioids. And that's a big one for me. Whenever I've talked about phantom limb pain management, I always say, and I always encourage people to try conservative techniques first, using medical management when nothing else works, because we know that these powerful medications can really just throw a monkey wrench into your day, right? Powerful medications with powerful side effects that can also lead to some pretty nasty addictions. And many of you have come to me saying, there goes Bob. Many of you have come to me saying that you want to get off of some of these opioid medications. So that's why this particular study really caught my attention. All right, let's see. Oh, here's the good question. Carl says, would you also comment on RPNI?
Ah, wow. So RPNI is
TMR's little sister.
How about cousin?
Cousin. Okay.
But it's the same concept. So that when you, I call it the muscle taco. When you have a nerve ending and you put a free muscle graft on the end of it, the muscle graft, as it comes back to life, sprouts nerve receptors. And so the nerve will reinnervate this piece of muscle. Now, it's a muscle graft. And so the engraftment process always has a little bit of issues of how big a piece you can put in. TMR, I'm having a block of denervated muscle and all the receptors there. And so the nerve can reinnervate a big block. RPNI, it may be limited to the size of the nerve. And so when they're bigger nerves, the inventor, who's a really smart guy at the University of Michigan, Paul Soderna, cuts the nerve into pieces and wraps muscle tacos around each of those pieces. So that's not, I mean, again, I did 4 TMRs on a below knee, and I was missing one place to put one final small little nerve. So I did an RPNI on that one. So I do RPNIs, but I'll do TMRs first. And there are many more TMR patients than RPNI patients, at least in the literature. Probably like there are something like 350 reported TMR patients in the literature versus only like 75 RPNI outcomes. So we'll see. It'll be some combination of both techniques, I suspect.
Okay, there we go. And then Susan, that's a good question. She says, my surgeon asked me to flex my muscle as he held it, and I could not make the muscle move. Is that bad? So Susan, first of all, I'd like to know which muscle he was asking you to flex. Was he asking you to bend your knee or was he asking you to bend your elbow? If I'm going to go out on a limb and say that if you're a below the knee amputee and you're bending your knee, okay, those muscles are going to probably be very weak. If you were not able to make the muscle move at all, then that certainly warrants your doctor looking into it a little bit more to see if there is any nerve damage there or if it's just extreme weakness. Sometimes if it's an extreme weakness, you know, for physical therapists, we grade muscles on a scale from 0 to 5, 0 being the muscle is completely paralyzed, 5 being the strongest. So sometimes when a muscle's at a 1 out of 5, you got to put it at a very certain position to pick up that little muscle contraction, Susan. Dr. Dumanian, you want anything to that?
Some people just have forgotten to flex. And so, but you look at history and, you know, if there's no reason that if they have bulk there, if there's no reason they should have had a nerve injury behind the knee, it'll be there. But my case of last week, you know, I couldn't really, it was above elbow, it was a shoulder dysartic, and he didn't have a great pectoralis function, but in the operating room with a stimulator, it was big and bulky and it was fine. So people turn off using their limb when they're amputees, and therapists encourage them to bulk up. If you have a bigger muscle, it's easier to detect a signal for a myoelectric, and I think it's better for a recipient just for pain.
And then later on down the line, Susan, this is where PTs, we love our toys. So sometimes if we have someone who has a very, very, very weak muscle contraction, we'll use something called electrical stimulation to help stimulate that muscle until it's strong enough to contract on its own as well. But again, that's a whole nother can of worms for later. Rhonda, how long has Dr. Dumanian been performing TMR surgery?
Well, I did the first one with Todd Kuiken in the operating room back in 2002. It takes 20 years on average for a medical innovation to get distributed throughout the world. And that's literally the aha moment was in 2018 at the microsurgery meeting. There were 1,000 people in the room, and I presented the first results of our randomized clinical trial where we took 2 groups of patients. Half got TMR, half got standard nerve treatment.
Mm-hmm.
We didn't tell the patients. And then the TMRs got better and the standard nerve patients were the same at 18 months. But what's really cool is that the phantom pain was getting better. And to our knowledge, it's still the only operation that helps phantom pain. And to show that there's some brain connection, on average, multiple surgeons have told me it takes 6 months for the phantom pains to really resolve. So you connect the nerve and the muscle are talking to the brain, and it takes a while for the phantoms to get better. It's cool, and no one has ever shown this before.
Okay, very cool. And guys, I want to tell you a lot of the questions that you've been asking tonight, all of these answers are pretty much on this TMRnerve.com website that I've been directing you to. So there's a lot of really, really great information there for this. And I do want to announce our second winner, Pam Hamer. Pam, congratulations. Go ahead and message me whether you want the coffee mug or the glass and send me your address and we will get that out to you. All right. So what happens? I always like to be open and upfront on the show about the good, the bad, and the ugly about everything we talk about on the show. What happens when TMR doesn't work?
Well, we start looking for other things. So we start looking to make sure that we look for heterotopic ossification. We get X-rays. We make sure the limb isn't ischemic. So we're doctors, and we're looking for a poorly fitting prosthetic.
Okay, there we go.
Now, twice so far. Maybe only twice did we have pain where I did the sewing. In general, that's not the problem. But you have sometimes when you have a painful nerve, the pain goes upstream on the nerve, and you didn't go far enough upstream to really take out bad segments of nerve. So there have been a few people where I've redone the TMR higher up, or I've re-explored the area and looked and found a neuroma at the sewing site.
Okay.
Or I missed a nerve. There's this one young child at the shrine where I did his baloney amputation. He was partly better, but he said it still hurts down there, and it hurts kind of like it did before surgery. And I missed one of his nerves, and so then I went back. I was ate some humble pie, and we dissected the area, and sure enough, he had a painful nerve right there. Right. And I just dissected it, did my standard TMR procedure, all of his pain resolved. So you gotta have humble pie. We're only human, and we can miss nerves too. Absolutely. Patients, this is really cool. Patients can usually, like you said with your finger, point exactly where the nerve is. So the doctor just has to listen and say, okay, and then you have painful spot and you localize with some numbing medicine and just explore it. The biggest change in my practice has been if someone is in pain for 3-4 months, don't wait for the year. It's really not going to improve between 3 months and 9 months. Just explore them early. And I think that's the biggest change in how I was taught versus what I hear now.
Yeah, no, and it boils down to quality of life. No, my patients call me the masochist because I'm a PT, so I don't have access to ultrasound or anything like that. So when they say about painful neuroma, I go, all right, let's go find it. And if I hit it, then I know it's either a bone spur that's really, really cooking or a neuroma, and then ship them out. At that point, it's just something, it needs to be addressed, because you can't move forward living in pain. A couple of you have talked here about some of the heavy duty medications, hydrocodone, gabapentin, and wanting to be rid of the medications. And again, guys, every clinician has their way of approaching pain management in their patients. As a physical therapist and seeing, post-op patients for 20 plus years, the way I approach pain medication is as a necessary evil. On a scale of 0 to 10, if your pain is at a 9, 8, or 9, the goal of the pain meds is not to get rid of the pain completely. You'd probably get snowed into a coma, right? The goal of the pain medication is to work with conservative methods to bring it down to a level where you can function. So whether that's functioning in the post-op by getting you up and moving so you can resolve that inflammation from surgery, or whether it's later on down the line, okay? And it's finding that balance. But for many of my patients, when I just see them and they just look defeated, when I see that my patients are looking defeated because they just don't see any way out of the pain, then that's the part where I say, you know what, we need to look at something a little bit more, such as surgery, and sending them off to a surgeon who can evaluate them, okay?
Surgery is not a failure. Surgery is not a failure. It's a new beginning.
It's an option. It's a now nice
it's an option.
Yes.
It is not. Oh, we did the amputation. It is a failure to go back to the surgeon. No, things change over time.
And
guys, trying to grow.
I don't usually give my personal opinion. I try to keep it professional. But if somebody gave me the choice between being on heavy duty narcotics for the rest of my life or undergoing surgery, and I've had my fair share of surgeries, y'all have heard my personal story, I'll take another surgery. I would. And I'm not negating how recovery from surgery. And that's actually another question that was on here, guys. How long is the recovery process from TMR?
Okay. So there tends to be a honeymoon period right after the surgery, almost no pain for a couple days. A painful nerve when you cut it kind of goes to sleep. Then it wakes up. The phantoms get a little worse. Mm-hmm. The local pain is different, but it's bad. Don't think it's not bad. And then for a standard patient, between 2 and 3 weeks, they're starting to get off of their narcos. And then it takes longer for the phantoms. But there's something else I want to mention. There's something called pain behavior. So pain behavior, you've learned that you've been in pain so long, you can't really almost admit it to yourself. And that's the last thing to change. So the first thing is people are moving more, they're wearing their prosthetics more, they're forgetting about their pain. And then you ask them, how you doing? And you're like, oh, it still hurts. It takes time to relearn that there's a new reality. So that's something, I had a patient today and, he was using his prosthetic, moving around. And I said, how are you doing? He goes, oh, it still hurts. I was like, yeah, but you're moving around a lot more. So anyway, it's a fascinating topic to look at all the manifestations of pain.
Yep. And guys, we're going to do our third and last giveaway for this. I love doing giveaways. Can you tell? For this evening, I just posted another link on some of the patient stories who have had TMR on the tmrnerve.com website. Okay. And the prize for this one, it's kind of my personal favorite. It's an annual subscription to my new Strong Body program. So thank you, TMR Nerve, for that nice little plug. So guys, for those of you who haven't heard of it yet, I launched a Strong Body program online. It has over 150 video exercises specifically adapted for above the knee and below the knee amputees. And I also have 2 books to accompany it, full of pictures, full of videos, full of me talk about how to do all these exercises and how it applies. So that's the prize. Yes? Have I got your attention? All right. Go to the TMR link that I just posted and tell me the name of one of the testimonies. Tell me the name of one of the people in those testimonies. Go. Oh, Brett already knew what I was going to ask. See, he's been watching this show too long. He already knows the questions. All right. So he's got that in there. Thank you, Rose.
I want to give 2 pieces of information.
Yes.
One is people keep asking, how long do you have to keep your leg off? It really kind of depends, but plan on 6 to 8 weeks.
Okay. So there you
go.
Lower
limb, 6 to 8 weeks to get all the swelling out so you don't need new sockets, etc.
Good.
The other thing is something that is really helpful for those of you who've had TMR is to do these exercises. So after the TMR, you want to move and open and close your imaginary hand, or if it's a below knee, open and close your imaginary toes. And that sends a signal to your brain, to the muscle quiver sends a signal back to the brain. And I think that really helps both pain management and the phantoms to go away. So do your imaginary exercises.
Yes. Does this sound familiar, folks? Does this sound a little bit like the mirror box therapy that I'm always kind of encouraging folks to do, and that visual imagery? It works. It works. It's all connected. It's all connected. And it's just really neat to do. All right. So we got a few things rolling in here. All right. So we talked a little bit about on the website questions that people should bring to their surgeon. So what is some of the questions and some of the information that they should be bringing to their surgeon on these first visits?
Well, your previous operative report.
Yep.
Bring your operative report from the surgeon. And I know this is pretty painful, to remember these memories, but any pictures of the amputation, if it was traumatic, is actually really helpful to the surgeon to know if the nerves were ripped or if they were cut. And so often I say to the patient, I know it's really bad. And many of them have them on their phones. So the operative report for anything that was done, if there was an attempt at neuroma resections, any x-rays, and, unfortunately, but you have to say it's a picture for the traumas.
Mm-hmm. Absolutely. And then are there any questions specifically that they should ask their surgeon?
Okay, how many have you done? Where'd you learn it? It's fun to think of where the etiology of your knowledge was, but so many people are doing this now. We've given courses around. I had a course at Northwestern where people got to watch a surgery, hear a lecture, and watch a live surgery. It was beamed from the operating room to a room next door where the surgeons were. So we trained 100 surgeons at Northwestern about this technique, and that actually helps spread out the information too.
Wow. Well, I'll be trying to sneak into an OR at some point to try to observe this myself if I don't get kicked out. Vikram, are Medicare patients covered? What are the insurance requirements to be covered for the procedure?
Standard nerve transfer. There's nothing experimental. This is standard of care.
Yep. So there were a couple of those that came in email to me this week, actually asking about the insurance question as well. All right, our third winner is Brett Sykes. Brett, congratulations! You are now part of the Cosi Talk Strong Body program. So you got to start doing those exercises now. All right, let's see. There was one other question. Oh, Julie, I am so glad you are listening today. She is an angel with wings, and she helps so many people out in the amputee community. So I know she's going to be giving out this information. Let's see. I think we've covered the majority of these questions.
What do you do? Okay, so the other thing is, if you're still in pain, get another opinion. Nerve stimulators are not wrong. They can be additive. So they're peripheral nerve stimulators you put in percutaneously through the skin at a pain clinic. There are stimulators that you can get, near the spine. And what do? They're stimulating the nerve to send the information up to the brain. But what does TMR do? It's getting kind of a natural stimulation of the nerve from a muscle going up to the brain. So these are all additive, and then one does not outcompete the other. So I think not having something implanted, something natural that's with you the rest of your life without batteries makes a little bit more sense.
Yes, absolutely. Brett says, cool kids do the exercise. Thank you, Brett. All right, guys. Guys, this has been an incredible evening. Dr. Dumanian, I cannot thank you enough for taking time to be here. I know you have very, very long clinic days. So you're still doing your homework. He's still doing his homework, guys. He was doing his dictations up until we went live. So I really, really appreciate your time and expertise. Like I said, to have someone who invented this surgery and pioneered this surgery, you can't get better information than from the source itself. And obviously a huge thank you to TMR Nerve. It has been a pleasure getting to know this company and its team behind the scenes. Jan and Beck, I'm going to give you a shout out and embarrass you a little bit. So thank you so much, ladies, for being such a wonderful support and for helping support the mission of this show to educate, inform, and empower the limb loss community. So guys, if we missed your questions, you know how to reach me. You can reach me on Facebook, on Instagram, through my website. It's all there. You can find me there. And guys, April 20th, we are going to have Dr. Dumanian back. Did they tell you that? You're coming back on the show. Did you know that? Yes. Okay.
I'll have my coffee cup then.
You're going to have, yes, I'm going to send you a coffee cup and a beer glass if you'd like one.
Sure.
I'll take both.
No, not two of them. One coffee cup, one beer mug.
Okay. Sounds good. But then you got to put something interesting in it during the show. That's all I'm saying.
We'll figure it out. Okay.
We're good. Okay. So we're going to have Dr. Dumanian back on the show to answer any of your residual questions from tonight. And we're also going to have Joe Cleven on this show. And well, I'm not going to tell you much about him other than he has a beautiful story. He's had TMR himself, and he's going to let you ask all the questions directly to himself. All right, guys. With that being said, as always, thank you for letting me be a part of your lives this evening. I will see you next week. Same bat time, same bat channel. God bless, guys. Bye.